Okay, hi everybody. So today I'm going to be presenting my half of our presentation on neurocognitive dementia, also known as a major neurocognitive disorder. So a little bit of overview about this disorder. So basically what was referred to as neurocognitive dementia in the DSM-4 has since been updated to major neurocognitive disorder in the DSM-5. That's how it is referred to now. You'll notice in the DSM-5 now that major neurocognitive disorder, major NCD, also has a counterpart called mild NCD. And in each of the subtypes of neurocognitive disorder, there's a major and a mild type. So basically the core feature of neurocognitive disorder in general is a noticeable cognitive decline in at least one area of function, at least one cognitive domain, based on both a voiced concern by either the patient themselves or an informant like a doctor, family member, caretaker, something like that, and evidence of decline, objective evidence on neuropsychological testing, usually some sort of objective testing that is used to prove this cognitive decline. So basically this interferes, the DSM explains that it interferes with independence in everyday activities. So it basically interferes with the patient's ability to complete activities of daily living, requiring assistance with paying bills, managing medications, in more severe forms, things like dressing yourself, feeding yourself, things like that. And the neurocognitive disorders are divided into subtypes by their etiology, basically what's causing the disorder. So the DSM starts out with explaining NCD due to Alzheimer's disease, which is definitely the most common of the neurocognitive disorders. It cites that 60 to 90% of all dementias are due to Alzheimer's disease. Basically, this type of NCD is characterized by a decline in memory and learning. There also has to be a decline in at least one other area of functioning, at least one other cognitive domain. But that decline in memory and learning, that is definitely the hallmark of Alzheimer's disease. It's accompanied by behavioral and psychological features for most of the time. They're frequent at the mild stage as well as the major stage. Things like, depression, agitation, aggression, either, things like that. The DSM explains that you can call Alzheimer's disease probable if there's evidence of a genetic mutation that points to Alzheimer's and/or a family history of Alzheimer's. Next, it describes frontotemporal NCD, which is a little bit different from Alzheimer's disease in that learning and memory function are generally spared, but we see the cognitive decline in either behavioral variants or language variants or both. So behavioral variant would be primarily behavioral changes such as apathy, disinhibition, depression, agitation, as well as a definite decline in social cognition, executive abilities, those higher level functioning that take place in the frontotemporal lobe of the brain. You may also see, and frequently you actually see both behavioral and language, you may also see decline in language abilities. So you'll see some of these symptoms manifested by poor judgment, lack of planning, distractibility, just difficulties with executive functioning, things like that. And again, the DSM denotes probable frontotemporal NCD if there's evidence of genetic mutation that's consistent with frontotemporal difficulties, or again, a family history. Also, that's potentially visible on neuroimaging like MRIs or CT scans. Next, it describes NCD with Lewy bodies. So basically what you're going to see here is variation in cognition and attentiveness and alertness. You may see a lot of fluctuation, back and forth. Sometimes patients have better days and sometimes they have worse days. But overall, you're going to see a decline in overall cognition and alertness and things like that. You're also going to see recurrent visual hallucinations, often detailed, well-defined, and definitely frequent. You'll see evidence of spontaneous Parkinsonism, and that Parkinsonism always occurs subsequent to the onset of the cognitive decline. So you won't see the Parkinsonian features first, you'll see the cognitive decline first. It also has possible suggestive diagnostic features. A lot of patients who have Lewy body dementia also have REM, sleep disorder REM, sleep behavior disorder, and severe sensitivity to neuroleptics, antipsychotic medications, in other words. It also describes a vascular NCD, so basically neurocognitive disorder that is related to either cerebrovascular events, such as a stroke, aneurysm, something like that, or a problem with cerebrovascular disease would cause it as well, like small vessel disease, white matter changes, things like that. So you'll see this would be called a probable vascular dementia if you can see objective evidence of either cerebrovascular disease on neuroimaging, like CT scans or MRIs, or if the onset corresponds with the cerebrovascular event. This is the second most common cause of neurocognitive disorders, first being Alzheimer's, like I said. And this can really be a heterogeneous presentation, as the DSM says. So, depending on which parts of the brain are affected by the cerebrovascular event or disease, you're going to see different symptoms. So it also describes a bunch of other different subtypes. NCD due to traumatic brain injury, which obviously would occur immediately after TBI is sustained. This also has a pretty varied presentation depending on which area of the brain was damaged. There's substance and medication-induced NCD, which basically occur when there are neurocognitive impairments beyond the typical duration, what's to be expected of intoxication of the medication and the acute withdrawal period. So the neurocognitive decline persists beyond the typical duration and development course of the medication difficulties. So there's also NCD due to HIV infection, due to prion disease, such as Creutzfeldt-Jakob syndrome, things like that. NCD due to Parkinson's disease, due to Huntington's disease, due to another medical condition that they don't describe. There's NCD due to multiple etiologies, and then there's, of course, unspecified NCD. So I'm going to play now a little short video that I found on YouTube that follows, it's basically a clip of a series of short videos about this woman named Nora Jo. Her granddaughter takes care of her and follows her, makes these videos about her. This one really touched me because honestly it really reminded me of my own grandmother who has Alzheimer's disease, and it's a really good short little picture of what it's like to suffer from this disease. Honestly, I would really say that you should watch all the other videos about her as well if you have time. They're all pretty short, just a couple minutes here and there. But together they really paint a good picture of the ups and the downs, and the good times and the bad that come with having Alzheimer's. So I'm going to play it right now.
So you said you found out a bunch of crazy stuff today.
Well, yeah, my God, I thought my husband was still living.
No, where'd you think he was?
Around. When they told me that he was gone, I couldn't believe it.
But you're okay though, right?
Well, I don't know.
You're okay, Graham. Graham, you're okay. Listen up. Here, give me the hand. We do the hand holding. Listen up. Fritz, you know his name, right? Fritz? Yeah. He's been gone for 6 years and he died in his sleep.
Who takes care of me?
I do.
Before you come.
No. Oh, you've been living with us for 2.5 years, and before that, you came up to our house every weekend for about 4 years.
Who took me up there?
We did, Pete and I. You came to stay at our house every weekend until you couldn't live alone anymore, and then we moved you in permanently.
Oh my God.
So you used to know every day. You just forgot. You forgot today.
What did he die from, honey?
Well, probably heart failure. He had Alzheimer's disease, but when people die in their sleep, they usually have a heart attack. You know? So he probably had a heart attack in his sleep.
I thought he was still living.
Well, if he was living, he'd be by your side.
Well, I thought he was around.
You're stuck with me, lady. So I know I'm a distant second to Fritz, but I'm better than nothing.
Oh my God, honey.
I'm better than nothing, hey? It's okay, Graham. It ain't easy getting old.
And learning the truth.
It's fun to be surprised that you have a beautiful little great-granddaughter, Jazz, every day, but it ain't fun to be surprised that you lost your husband every day, is it?
No,
No, that's
I
bad
loved
news.
him dearly. And I thought he was still around. We're old.
Yeah, we'll get your mind off it. Well take you home and
I'll
get your
get my
mind off.
mind off it.
Yeah, you'll be okay.
I'll have a bottle of beer
There we go.
and get my mind off it.
Perfect.
All right, so